Once again, continuing with our discussions of anatomy with respect to motion, or motion being the central part of our network of meaning or our semantic network, we're looking at elbow flexion. Now, our main objectives here, a specific discussion of what elbow flexion is with respect to planes and axes, a general discussion of the muscles that flex the elbow, very general discussions of the nerves that supply these muscles. We're looking basically at the musculocutaneous and the radial nerves. We'll touch that really quickly. A very general discussion of the vascular supply, so brachial artery and radial recurrent artery, and general discussion of the areas to assess and treat should elbow flexion issues be suspected or reported. Now, just a general note, more often than not when we're talking about the areas for issues with elbow flexion, what I should say is that the underlying assumption is that elbow flexion is difficult, right? Or rather, the elbow is flexed. So the elbow is flexed and it will not necessarily extend. So most of this should have been a note that I made much earlier on in the series, but whichever movement that you're having a problem with is the movement that we're talking about. So that's why you would treat the muscles involved if it is found to prefer flexion or be stuck in elbow flexion in this particular case. Now, as far as planes and axes, so we do our quick review of each plane and each axis. So the axes are perpendicular to the plane, very generally speaking. The sagittal plane is a 50% cut of the body left to right with a horizontal or transverse axis. The horizontal or coronal plane is a 50% cut of the body top to bottom, and it's got a vertical axis, so horizontal or transverse plane. The frontal plane is 50% cut of the body back to front. So frontal or coronal, 50% cut of the body back to front with an AP or PA axis. With respect to elbow flexion, because the relationship between the three bones, the humerus, the radius, and the ulna, primarily the humerus and the ulna, that relationship is stable. You can technically say it's happening in other planes, but elbow flexion with respect to the anatomical position, so the anatomical position being the arms at the side with the palms up or the palms in supinated position, elbow flexion is in the sagittal plane on a transverse or horizontal axis, and that is primarily the interaction between the humerus and the ulna. Now, that said, the elbow flexion can happen wherever the arm is, but generally speaking, with a stable point of reference being the anatomical position, elbow flexion is in the sagittal plane on a transverse axis. So it's closing of the elbow joint, right? So approximation of the forearm flexors and the elbow flexors, right? So this and the biceps, it's like you're making a muscle, right? So this is elbow flexion. It can happen almost anywhere that the arm is, but the relationship, again, between the humerus and the ulna is fairly stable. So it's just closing of that joint, regardless of where it is, but with that stable reference point of the anatomical position, it would be considered within the sagittal plane. But again, just to go over this and over this, it can kind of happen anywhere because that relationship between the bones is fairly stable. Now, we just take a really, really quick look. As I already noted, you've got the humerus and the ulna as the primary dictator of motion of the elbow itself, right? That's where the relationship really is. But then you have the ulna, right? So you do have or rather the radius, you do have a relationship between the humerus and the radius. But the thing about the radius is that it is the thing that will roll in the forearm. So this motion really is the motion of the radius, and that is held in place by the annular ligaments. So you've got a bunch of ligaments around here. You've got them going from the humerus to the ulna, and then from the ulna to the radius, and then you have them from the humerus to the radius as well. So you've got a bunch that are going to blend in. You've got joint capsule, and then you've got these divisions of that. So you can see it just basically looks like a big old mess. If you see it, now this is obviously an artist rendering, but there's a bunch of ligaments there. So you've got your radial and ulnar collateral ligaments, you've got the annular ligament. So you've got a bunch of stuff happening there to kind of keep this together. The elbow itself is really the humerus and the ulna, but there is connection between the humerus and the radius. So just to make that, or to kind of bring that top of mind so that that's there. Now, as far as the neurovascular bundle, so as I noted, for the muscle, well, this is actually the muscles and the neurovascular bundle together more or less in one slide. So the muscles they're going to flex the elbow, biceps brachii, brachialis, and the brachioradialis. The biceps brachii and the brachialis are going to receive motor tone from the musculocutaneous nerve, and then the brachioradialis is the radial nerve. Then you're going to have primarily the brachial artery feeding the biceps, and I believe also going to feed the brachialis, and then you're going to have the radial recurrent artery giving blood to the brachioradialis, and I believe some contribution of blood to the biceps brachii, especially as you get down lower. So you've got all of this kind of in confluence, especially on the anterior surface of the elbow, where you'll have the cubital fossa, and you'll have all of these, I think it's the median cubital fossa. I may be messing that up, but cubital fossa, median cubital fossa. You've got a bunch of neurovasculature running in there. So it's got a lot of relationship to the bicep itself and to the bicep tendon. And as the bicep tendon comes down, you can see it kind of on the picture, it's going to shoot off that way. So it's coming down and then shoots off that way, the bicipital aponeurosis. So there's a bunch of connective tissue there. As far as the muscles that are going to generate the motion, biceps brachii, brachialis, and brachioradialis are going to be the ones that are going to generate the actual flexion of the elbow, so the closing of the elbow joint. And then the, as I noted, musculocutaneous nerve, radial nerve, and then the brachial artery and the recurrent radial arteries. So as far as dealing with all of these structures, more or less, as far as the elbow is concerned, if you come down the anterior surface of the humerus and deal with the biceps itself, on some level, as you get lower down, you're dealing with the brachialis. And then as you get down past the elbow or into the area of the elbow, it's not going to show well here, but here, brachioradialis, you're going to be able to come through here. So you're going to be able to deal with the soft tissues in whatever state that you find them. And if you are trying to chase the neurovascular structures, as always, you're going to have some challenges because the neurovascular structures will have variability from one person to another. But if you deal with the motions and so the motion dysfunctions that you find, as well as the issues with yield to pressure on the soft tissue. So as you push into the soft tissues, if they do not respond as everything around them does, if they're higher toned, if they don't yield well, then you know that you have a motion problem with the soft tissue in relation to other things, or at least in relation to the bone. If you respond appropriately to those findings, you will respond accurately to the issues at hand. And if there is a relationship between the lack of motion and the lack of yield to pressure, there's also lack of motion just with respect to the muscle in relation to the bone. If you respond to those appropriately, then you're dealing with the situation at hand. And if there is a relationship between that lack of motion or that alteration in motion and the neurovascular bundle, then you'll deal with them in a collective fashion. And you can see why this continues to be a theme over and over again. If you deal with the motion problems that you find, if there's a relationship with the neurovasculature, you'll deal with them together instead of chasing the blood vessel and the nerve. Find the motion problem and you'll deal with what is occurring as accurately as you're able. All right, so again, just a quick overview or a quick recapitulation. Biceps brachii, brachialis, brachioradialis, you're dealing with the musculocutaneous nerve and you're dealing with the radial nerve. And then as far as blood's concerned, you're dealing with the brachial artery and the radial recurrent. But all of those structures, you'll get here and just the elbow in general. You'll interface with those on some level. So again, if you're dealing with emotion, that's the best thing to do. So as already noted, in part, the areas of consideration for assessment and treatment, because of the neurovascular bundle, you want to consider the cervical column, you want to consider the clavicle and the axilla, again, the neurovascular bundle. So as the axillary artery turns into the brachial artery, as the branches of the brachial plexus descend in relation to the axillary artery and the brachial artery, but branching off primarily in and around the axillary artery, you're going to be able to trace the neurovascular bundle and identify any motion issues that are present in that region. So as I said, that's basically just working on the bicep itself in relation to the humerus. The anterior soft tissues of the arm, as I already noted, so that's for the neurovascular bundle, but that's where you'll interface with the biceps brachii and the brachialis, and then the anterior and lateral surface of the forearm. And so the brachioradialis and the general connective tissue, so the bicipital or the biceps aponeurosis shooting across the arm, and how that's generally going to interface with the neurovascular bundle in and around the elbow, as well as the contribution or the region of the brachioradialis. So you're working your way down the arm up to the elbow on that anterior surface. And when you get below the elbow, you go anterior surface and lateral surface. Now, as far as contraindications and red flags, once you get into the arm proper, once you get down in and around the elbow, you're not as likely concerned about, or you're not as likely to find issues with severe dramatic changes in cognitive function or respiration. If those are present, that's kind of an all the time thing where you send that out for further medical examination. But with respect to the elbow itself, when you're narrowing in and paying a little bit more attention to the elbow, any known fractures or tears in the region, you do not treat. Any suspected fractures or tears, you send out for further medical examination. So we're kind of narrowing in and saying, once you've narrowed your focus and everything else seems okay, and there's no major danger presented to the patient, then the thing that you're most likely concerned with in the region of the elbow itself is known or suspected fractures or tears.